Good morning, everyone. My name is Karen Larsen. I'm the Chief Executive Officer for the Steinberg Institute, and I'm going to be your moderator for the day. The Steinberg Institute, our mission is to advance sound public policy and inspire leadership on issues of brain health. Prior to this job, worked as the Health and Human Services Director for Yolo County, overseeing all public health, social services, and behavioral health services for that county, and worked in an FQHC for about 15 years before that. So this panel is personally very exciting for me to be a part of. I think most importantly, in the context of this conversation, I'm also a gay woman in recovery who found herself involved in the criminal justice system when I was 19 years old. And so this panel has this very special place in my heart, and really excited to hear all of the conversation today. Next up is going to be Abbie Totten. She's the plan president for Molina Healthcare of California. She's been a healthcare executive for almost 20 years and specializes in Medicaid and California Medicaid managed care environment. She has extensive experience in the Medicaid public policy and managed care operations. Most recently, before joining Molina, Abbie was the medical program officer at HealthNet, where she was responsible for their $7 billion California Medicaid business. And she's also worked at the California Association of Health Plans and Local Health Plans of California. So I'm going to welcome Abbie and turn it over to her.
Thanks, Karen. As I always like to say, I'm a longtime a Medi-Cal policy geek. It's what I do. It's what I love. I really want to thank everyone for being here today. This is an important discussion on how to really drive innovation in healthcare solutions to meet the needs of our underserved populations. Before we get started today, I am absolutely just pleased and excited to introduce LA County Supervisor Holly Mitchell as our opening speaker today. Supervisor Mitchell is a champion for increasing access to safe and quality healthcare across Los Angeles and across the state of California. She's currently serving as the chair of the LA Board of Supervisors, but really her leadership came from the fact that she is a daughter of public servants and a third generation Angelino. She leads with an incredible understanding of the vital safety net of LA County and the service it provides to millions of families every day. She was elected to the Board of Supervisors in November of 2020 and has made poverty alleviation the #1 priority in the county, and really has anchored her work in equitable recovery plan from the health and economic pandemic that has been caused by COVID-19. Within her first year as supervisor, and with the support of the County Board of Supervisors, Supervisor Mitchell passed a landmark guaranteed income program. This made LA County the first in the nation to phase out urban oil drilling, and has strengthened the county's ability to quickly respond to mental health crises among our unhoused residents. Before serving as the first on the first woman-led Board of Supervisors in history of LA County, Supervisor Mitchell also served for a decade in the California legislature as a representative for the 54th Assembly District and the 30th Senate District, both in LA County. During her tenure, she passed over 90 bills, including landmark anti-hair discrimination laws, the Crown Act, making California the first in the nation to pass this law ending hair discrimination. We are extremely excited to have Supervisor Mitchell joining us today, and I hope everyone enjoys the panel.
Good morning. I'm Holly Mitchell, chair of the LA County Board of Supervisors, and I'm honored to share remarks at today's Molina Cares virtual panel. The COVID-19 pandemic put a sharp focus on pre-existing healthcare, housing, and homelessness issues that have grown worse over the last 2.5 years. In the 2nd District that I proudly represent, essential workers who can't telework or who have to interact with the public regularly have been particularly affected by the recent rise in COVID-19 cases. My office has been vocal in the need to leverage time-limited American Rescue Plan Act funding to invest in innovative solutions such as telehealth and bridging the digital divide. High-quality internet access has become even more necessary for work, education, and healthcare purposes. In April of this year, I'm proud to share that LA County launched a guaranteed basic income pilot program for 1,000 qualifying individuals and families at the direction of my motion in collaboration with my colleague, Supervisor Sheila Kuehl. Our guaranteed income pilot is called Breathe, and it's based on the principle that providing a flexible income that an individual can use for education, childcare, housing, healthcare needs is one of the most effective ways of reducing poverty. We're empowering people to make the decision that's best for them by giving them a guaranteed basic level of income. I really look forward to the fact that we'll be evaluating this pilot very carefully to see what works to help us disrupt the cycle of poverty, disrupt the cycle of multi-generational poverty, and improve the lives of Angelenos. I also currently serve on the LA Cares Board of Governors, and I provided input on the rollout of the CalAIM Enhanced Care Management Benefit and Community Supports. As many of you are aware, adapting the model of care developed through the county-led whole person care pilot has required flexibility and collaboration to build on the lessons learned from all of the previous 1115 waivers. So I'm really glad to see the Transitions Clinic Network represented on the panel, given their expertise in using community health workers to assist people transitioning from prison back to their communities. I believe in the value of community health workers across the board, so 2 thumbs up for me. Our LA County Department of Health Services team adapted many of the Transitions Clinic Network's successful strategies through our own whole person care pilot. This year, I authored a motion to create a plan for expanding the county's Care First Jails Last vision by addressing the crisis of a rising jail population with serious mental illness and substance abuse disorders. As you all know, our Black and Latinx communities, many of them located in LA County's 2nd District, are disproportionately impacted by incarceration. The motion calls for a strategy for expanding the Office of Diversion and Reentry's housing program, also known as ODR, to include 500 additional beds so that a total of 2,700 beds will be available for individuals in our jails that desperately need treatment for serious mental illness. These are just a few examples of how my office is committed to addressing this critical need for holistic solutions for strengthening the health of our communities by focusing on addressing our homelessness crisis and improving our justice system. Quite frankly, to make it truly just. Thank you for the opportunity to make a few welcoming remarks for this really important panel discussion on social determinants of health and innovative strategies for increasing healthcare access and quality. I look forward to hearing more from the panelists and continuing to be your partner in collaboration. Be well. Good morning.
Thank you to Supervisor Mitchell for her remarks and her ongoing commitment to these issues. Really excited to dive into the discussion about how California's organizations are using innovative solutions to meet the healthcare needs of underserved communities. And I'm going to turn it back over to Abbie to speak a little bit more about Molina's work in California since the start of the pandemic.
Oh, thank you, Karen, and a special thank you to Supervisor Mitchell for the incredible remarks. There is so much amazing work that's going on around our state to really drive innovation and change. You know, as the plan president for Molina Healthcare of California, part of my role is to really bring to the table innovative solutions to help improve care for our members. We know that particularly underserved populations, the traditional model of care has not moved the needle in the way we'd like to see it. So looking to bring innovative partners and develop programs that target physical, behavioral, and social drivers of health in order to truly improve care is essential to the long-term goals of both ourselves as a health plan that serves underserved communities, as well as our primary contractor, the state of California. The way that we do that is really sitting down and looking and listening within our local communities and ensuring that we're engaging partners where they are and in the ways that they need us to, and making sure that we are looking at every potential opportunity to improve care and bring care to our members. And, you know, we all know that you can show up in your primary care provider's office and have your annual wellness exam, but healthcare is not simply about going to your primary care office. It's about the high quality holistic care for your life at every aspect of coverage, whether it's where you live, it's in your schools, it's in the health fairs. We have to engage as a health plan across our diverse communities. Our highest priority is ensuring that we have programs in place to serve our vulnerable patients at the community level. Some of the fun innovations that we've been working on over the pandemic have included everything from new vendor partners that are getting care into the hands of our members, working on the establishment of our mobile presence from our RVs and our drop shops to our one-stop shops across our service areas to make sure that we're there in the community where people need us most. But what I really am excited to hear from today are our panelists. The panelists we have today for you are leading the way in innovation. They are at the front lines of developing and deploying solutions to ensure high quality health and wellness for our most complex populations. And this is at a time when the state of California is devoting significant resources to bending the curve and ensuring equitable and coordinated care across the Medi-Cal population. We know that the pandemic has disproportionately impacted many populations in our state. And so hearing from all of these great organizations on how we can look to new delivery system models, new innovations in care to improve the health and well-being of Californians is going to be an incredible opportunity for all of us today. So Karen, I'm going to kick it back to you to introduce our panel members.
Thanks, Abbie, and thanks to Molina Healthcare and Molina Cares Accord for bringing together this great expert panel. I'm going to do a really brief introduction of each of the panel members. They have extensive, unbelievable experience and history, but I want to have plenty of time for the Q&A section that we have to come. So I'm going to start by introducing Gabriel Maldonado from TruEvolution. He's a leader on LGBTQ+, HIV, housing, and health disparities. 15 years ago, he founded TruEvolution, and this has grown the organization from offering HIV and STI prevention and care services to now including mental health, emergency housing, and leading the organization's $25 million housing development work. He previously served on President Barack Obama's Presidential Advisory Council on HIV and AIDS, and serves on many regional boards, including Planned Parenthood of the Pacific Southwest, Borrego Healthcare Foundation, and global organizations such as the AIDS Healthcare Foundation. He's also an advisory member for Healthcare's National Advisory Board, as well as Merck & Company. So thank you, Gabriel, for being here today. Next, we have Meredith Chanda from the Maven Project. Meredith is a board-certified family nurse practitioner with over 15 years of experience within multiple facets of the medical community. Prior to joining the Maven Project, Meredith previously worked as the director of Telehealth for a nonprofit community health clinic, where she pioneered the rollout of a successful telehealth initiative, delivering primary care to the uninsured patients of rural southern Georgia. Meredith specializes in the use of technology to optimize patient outcomes and to improve access to care for vulnerable populations. She believes the adoption of digital health services is integral to the correlation of inequities in the modern medical landscape. And next, I have Bethany Divakaran from Transitions Clinic Network. Beth is a public health nurse with extensive experience in organizational and system transformation aimed at addressing social determinants of health. She leads the Transitions Clinic Network Reentry Healthcare Hub and works closely with the California State Prisons to ensure care coordination from prison to primary care clinics. TCN is a community-based organization supporting the healthcare reentry of people who are formerly incarcerated, engaging patients, and transforming the healthcare system by hiring community health workers with lived experience of incarceration. She has has a doctorate in public health nursing and master's degree in public health from the University of Minnesota, and she has worked as a nurse leader across hospital, clinic, and governmental settings. With all that, we're going to get into our discussion about how California providers and organizations are advancing these innovative solutions. And I'm going to start with Gabriel. Good morning, Gabriel.
Good morning.
One issue that you are leading on is housing. With TruEvolution's work through the Project Room Key program, one of the focus areas of CalAIM the state of California's effort to transform how it delivers services to the Medi-Cal population is to provide supports that get to the root of the social drivers of health. Can you tell us how housing is a determinant of health outcomes in the populations that you serve, and tell us about your work connecting the members with housing and support?
Yeah, so first I want to say thank you for inviting me to the panel, and thank you to all my colleagues for allowing me to have space with you. So my organization has been involved in housing since 2017. We began as an emergency supportive housing provider. So this utilizes hotels and motels as a means for rapidly housing folks. We had a network of about 10, 12 hotels across Riverside County. And in 2020, when COVID-19 happened, we participated as providers in Project Room Key. Now, we were specifically asked to take on people living with HIV as a special population, because that was an area of our focus. It's a core competency of our work. We were told to anticipate about 20 clients throughout the duration of the program, and we received 72 in the first 2 weeks and 87 throughout the term of the program. So these were all people living with HIV. These were all individuals that were missed in the most recent point in time homeless count that had been done that year, just prior to 2020. And I think what this really revealed is that people live in a very wide spectrum of housing stability, and there are many pressure points, social determinants that are forces that really contribute to a person being right at the cusp of stability and then being in a very precarious state of instability, whether it's housing or losing a job or being able to then have continuous coverage, or all of the many supportive services that are needed to be able to live a full, well life. There may be elements missing. And so we all know that these things are necessary to living a full and healthy life. And I think what COVID-19 did, and what housing does in particular, is it really highlights a person's 24 hours. You know, when you are taking care of someone in a housing facility round the clock, you really get to see what the basic needs really are of a person throughout the course of a full 24 hours. And so our goal is to now lead in housing development. This is a new frontier for us for the last 2 years. And so we've been recipients of Project Home Key, which was the state's second iteration. And so that's kind of our vision, is to use housing development at the forefront of building out medical and social services.
Thank you so much, Gabriel. Having participated in some of those Project Room Key and Home Key projects in my prior position, I can testify to the impact on human lives. So thank you so much for all your work. Bethany, I'm going to turn to you. Your work with people who are returning from incarceration to the communities from incarceration is really unbelievable. And I'm hoping you can tell us more about your model and how you've involved people who are formerly incarcerated in the process of developing this, your services, and really thinking about everything from addressing continuity of care to providing culturally competent services. To share a little bit about what TCN is doing.
Great. Yeah, happy to do so. Thanks for having me. Thanks for the question. So the Transitions Clinic Network, or TCN, we are committed to changing the primary healthcare system to address the needs of people, as you said, who are coming home from incarceration, who have chronic health conditions. We are a national organization, so we have programs in 14 states and in Puerto Rico, and we've been working to build an extensive network of programs here in California. So we currently have 21 sites in 14 counties in California. For some background, we know that the population of people coming home from prison and jail have higher medical and social needs than the general population due to the impact of this system of incarceration. So a great example of this was with COVID-19, how people in prisons were actually 5 times more likely to get COVID. People's health conditions tend to worsen when released. In fact, people coming home from incarceration are at 12 times higher risk of death in the first 2 weeks after release. And it can be really difficult for individuals to transition their healthcare from the carceral system into the community. And people coming home are balancing so many multiple different priorities, from housing and jobs and reuniting with their families in addition to their health. So our program, TCN, we aim to engage returning community members in healthcare programs that are still very much a part of the community primary care system, but are tailored to the unique needs that they have. So clinics adopting the TCN model of care hire community health workers or CHWs with lived experience of incarceration and reentry as members of the primary care team. So these community health workers serve such a key role in engaging patients in care. That includes meeting patients prior to their release, locating patients in the community to invite them into care, assisting patients with navigating and meeting social needs like insurance and transportation and food access and employment opportunities, and then connecting patients to healthcare services, which in our clinics include medical care, as well as mental health services, substance use disorder treatment. All through the way the community health worker is serving as a mentor and a cultural interpreter for their patient as they're engaging with these different systems. So in this way, our model is kind of seeking two things. We want to meet the needs of the individuals who are coming home to their communities. Our model is evidence-based. It's shown to improve health outcomes, such as preventing emergency room visits for individuals and also reducing days of reincarceration for our patient population. And we're also looking to transform these systems. So looking to remove barriers to employment within the healthcare system for people who have that lived experience of incarceration, and also developing the healthcare system's capacity to serve the unique needs of this population. I think we all know how hard it is to move systems. So all of this takes just so much collaboration and cultural competency and humility and ongoing learning. So that's another reason why it's really great to be here today to share about our work and to learn about the work that others are doing as well.
Thanks so much. I so inspired when we can engage people with lived experience in our systems, serving those same people. I feel like often the people we serve really say that those are the services they get the most from, not the people prescribing medications or the like. So thank you so much for your work around that. I'm going to turn over to Meredith next. Meredith, I know the Maven Project model is based on helping people to access specialists through telehealth consultations. And I know you're working with Molina to provide services at 10 clinic sites throughout California. Can you share how you reach people in medically underserved communities and how telehealth has enabled you to connect those patients with specialists where they otherwise wouldn't be able to have that access?
Absolutely. And like my colleagues, I just want to thank Molina Cares for the opportunity to speak today and to share the Maven Project's mission. We are very excited for our upcoming partnership in California. And for those of you who are unaware, Maven Project is a national nonprofit working to address social, racial, and economic inequities in healthcare. We have built an incredible core of expert physician volunteers when we connect with frontline community health center providers via our telehealth platform. So while technically we are a telehealth company, I really like to think of us more as a medical community that's facilitated by technology. Our main mission is really to empower frontline primary care providers to practice at the top of their license and to feel comfortable and confident treating what we often know are very acute and highly complex patients with many social determinants of health barriers that can limit a patient's ability to access specialty care outside of their medical home. So in support of this mission, our physician volunteers provide unlimited peer-to-peer medical consults, as well as continuing medical education and one-on-one mentoring to all of the clinics that we serve. We currently have over 160 physician volunteers in over 60 different medical specialties that we credential and train in order to understand the unique needs and the inherent resource limitations that come with serving communities in underserved nature. So how does this resource directly impact the patients that are served by these community health centers? Well, the literature shows that 1 in 4 visits to a community health center results in a medically necessary referral for services that are not provided by that clinic. So often patients are referred outside their medical home and they face numerous challenges such as complicated administrative paperwork, language or cultural barriers, and excessive wait times to see specialists. So an alternative to that is Maven Project. Maven Project can provide primary care providers with access to specialty care electronic consultations in on average 7 hours. And this often provides primary care providers with not only the support to manage and treat the patient's condition independently, but also the knowledge to address similar issues that they may face in the future. And interestingly, in fact, our post-consult surveys for our consultations for all of 2021 demonstrated that 73% of Maven Project consults allowed primary care providers to avoid sending their patients for an external referral altogether. So this not only increases the timeliness of medical intervention for these patients, but it improves population health outcomes while also reducing costs and simultaneously increasing both patient and care team satisfaction.
Really awesome. It's like so great to be able to get multiple benefits from the service, not only for the patients, but for the providers who get to really, level up their scope in treating these kinds of specialty conditions. So thank you so much. I'm going to return to Gabriel for a moment. Bethany talked about the work that Transitions Clinic Network does with a population that's often marginalized or underserved. And I'd love to hear from you as someone who's also working with marginalized populations, either people with different sexual or gender identities or health status or race or income level. What more needs to be done systematically and in the policy space to bring solutions where they haven't been offered before to the people that you serve?
Well, my organization is celebrating 15 years this year, so it's been a bit of a journey. But I think what has been consistent throughout that entire journey is that we are an LGBT organization. We primarily focused on serving the Black and Brown, Latinx community primarily. And, as we have, expanded our advocacy and expanded our services, you begin to really notice the thing we call disparities. And you begin to really notice the distinctions and differences in people's starting places and where they begin and their path to achievement in healthcare. And so I think for us, what we're constantly doing is fighting against a system that has a whole host of pre-existing policies, positions, and norms that oftentimes we are trying to push against, help our clients navigate around, advocate for something different, and create bridges when there isn't one. And I think that is part of the work that's done as healthcare providers. I do think that CalAIM, I have been so excited in its launch and in its concepts, because I think it is really the starting place to really undoing a centuries plus worth of inequities that have existed historically in a lot of the communities that myself, Bethany, and I have no doubt, of course, Meredith serves as well. Our clients are not just getting here today. And so for us specifically, I think in the Inland Empire, Riverside, and San Bernardino County, the LGBT community, youth, communities of color, we are often lacking the basics in safe spaces. So when you talk about accessing services, you talk about engaging in healthcare, you talk about being consistent in engaging in healthcare. Safe spaces is something that seems so basic and obvious and is very much lacking. And so for us, we are pioneering what we hope in the region is called the community campus model. And for us, a community campus is a facility that co-locates housing, medical, and social services in one parcel of land. All three are happening in one place. And so our hope is that that can be an approach to responding to many of the social determinants of health. And I think when you talk about CSS, community support services, and you talk about ECM, enhanced care management, those are actual frameworks that are really a starting place for us to provide sort of the complicated and comprehensive service delivery that is really needed for special populations.
Yeah, couldn't agree more on the potential of CalAIM and how exciting it is. So it sounds like your feedback really is
more money, more money, bigger, less eligibility requirements, more of the higher caps on being able to deliver certain categories for services. So sorry, shameless plug on advocacy there. Meredith, Bethany, help me. But yeah, that would be my shameless plug on advocacy.
Yeah, I think it's great. And I think we're all just anxiously awaiting what the implementation, how it's all going to roll out. So all of your voices will be so critical in that as we move forward. Okay, Meredith, I'm going to turn back to you. The Maven Project works directly with community health clinics and federally qualified health centers. And can you speak a little more about what that partnership structure enables you to do in terms of meeting your patients' needs and filling the gaps where they exist, especially in our rural communities? We have so many rural populations here in California, our high poverty areas, and our communities of color.
Yeah, absolutely. Thanks, Karen. That's a phenomenal question. And as you already mentioned, so we work exclusively with federally qualified health centers and free and charitable clinics. And that's because we all share a similar vision, which is expert healthcare for every individual when and where they need it. And as we all know, currently there are millions of Americans that lack access to quality, comprehensive healthcare. Nationally, 63% of healthcare patients are members of either a racial or ethnic minority, and that's compared to just 40% of the general population. And 91% of health center patients are at or below 200% of the federal poverty level. And the most common barriers for accessing specialty care for these groups include the inability to secure time off work, childcare needs, lack of transportation, and distances to specialists, particularly in rural communities, like you mentioned. Meanwhile, we've seen over the course of the last few years, safety net clinics are experiencing increased patient demands while simultaneously suffering from challenges in both recruitment and retention of not only physicians, but all healthcare professionals. And that's become an even bigger challenge since the start of the pandemic. In the US, the median wait time for specialty care appointments is 56 days, and actually can be as long as 108 days for high demand specialties. And what's interesting is that these wait times are often compounded not only for Medicaid patients, but for uninsured patients. And these delays can pose potentially dangerous delays in medical care. But Maven Project, what we're trying to do is have a really holistic approach to help solve for this problem. So our timely virtual consultations in conjunction with ongoing education and mentoring, we hope to have both an immediate and lasting impact with these interventions. So not only can patients avoid really long wait times to see specialists, but they're avoiding travel and out-of-pocket costs associated with their specialty care referrals. While simultaneously, providers are feeling supported, and the knowledge that they gain can be applied to future patients. And I think even more so, a benefit of avoiding unnecessary referrals is that we are reducing the backlog of patients waiting to be seen by a specialist. And this is important because the patients that truly need to be seen for in-person care can actually be evaluated sooner as a result of this programming. And I wanted to mention, because this is something I found out very recently and was very surprising to me, but I read a recent study in the Journal of Healthcare for the Poor and Underserved, and it found that providers and community health centers cited insufficient resources for my patients as the #1 cause for their burnout and attrition. And this beat out things like salary and work-life balance. And so for Maven Project, what's important to us is ensuring that providers feel very adequately supported, because we know they play such an incredibly important role in maintaining the health of our communities.
Thank you so much. I think, workforce is something that we're all dealing with. And I think it's really easy to start with saying, oh, well, we need to pay people more, give them better benefits. But it oftentimes is, especially in our spaces where our workforce is so mission driven and committed to the people we serve, really focusing in on how we can deliver better care, better access is just so critical to provider satisfaction. So thanks for flagging that for us as well. I'm going to turn back to Bethany now. We talked a little bit before about California's efforts to improve healthcare for specific populations, including the formerly incarcerated population. That's a big part of CalAIM. You have the perspective of working on the implementation end of that effort by directly serving your members. And Gabriel, I think you spoke to this a little bit, but I'm hoping you can tell us what you think are the most important areas that need to be addressed from a structural level for improving health outcomes and truly delivering whole person care for our formerly incarcerated population.
Yeah, absolutely. I think, again, most importantly, people impacted by incarceration must be involved in working toward the solutions. Our TCN model of care was developed in 2006 in San Francisco through input by communities impacted by incarceration. And we learned that it's these individuals in these communities that have been impacted that know the most about what care should look like, right? Care that is holistic and non-punitive and non-stigmatizing and patient-centered. And it's so important that we continue to include the input of impacted community members, not just at the beginning of the process, but at every step in the way. So some ways we do this organizationally is by, like I mentioned, having people with lived in history of incarceration on our team as colleagues, and we also have a community advisory board that informs organizational decisions as well, made of current and former patients. And our our organization most recently has been working to make sure that the voices of people impacted by incarceration are included in decisions that are being made about CalAIM's Justice Involved initiative. So these are the folks who should, literally be sitting at the table at these advisory board committees. A second point I'd like to make, thinking about structures, is there's so much opportunity for the healthcare system to play a role in undoing the harms of mass incarceration. So when I speak of mass incarceration, what I mean are these past 4 decades of policies that have increased the populations of people who are behind bars and under supervision. And we know that these policies have disproportionately impacted Black and Brown communities and have resulted in significant health disparities. Community primary care clinics can consider how to better serve returning community members, such as offering more social supports to meet reentry needs, integrating behavioral health services into the clinic, and revising policies that in order to make the clinic feel like a more welcoming space for people coming home. So you can imagine like someone who's been in prison for decades coming home to their community, having to navigate the bus system for the first time to get to their first appointment on time. Usually patients who show up late to their appointments are going to get turned away. And just as an example of revising policies to make them more accommodating, our programs will make accommodations for this patient who we know took significant effort to show up today. And something, again, that's so critical to our work of serving patients and undoing these harms is creating opportunities for people within healthcare to be hired. People who have that lived experience are individuals who have the most trouble finding good jobs, but who also have the experience in order to serve other people coming home. We know that the healthcare sector is one of the fastest growing sectors of employment and historically has excluded people that have criminal records. And so our program is really seeking to promote health equity by creating opportunities for people with lived experience of incarceration to be hired into well-paying jobs that allow them to leverage their experiences and their expertise to serve this population.
That's great. Like a pipeline you're creating of formerly incarcerated people and that reentry, from reentries through reintegration. So thank you so much for that. I think I forgot to mention at the beginning, but I'm sure everyone that's participating has picked up on the fact that your lines are muted, and we are encouraging you all to submit questions. You can either use the Q&A or the chat feature, and we'll do our best to kind of group similar questions together and respond to those here at the end. I'm going to shift topics a little bit. I'm going to go back to Abbie, bring her back into the conversation. We've talked a lot over the past several minutes about what the organizations are doing and providers, what innovative tools they're using to meet the needs of our members. And I'd like you to kind of talk about what are health plans in general doing, and Molina in particular, to support these models and improve the health outcomes of your members.
Yeah, thanks, Karen. I love sitting here listening to our panelists today because they really do represent the best and the brightest in the incredible innovation that is out there. As a health plan that serves in Medi-Cal, our #1 priority has to always be on executing on the state and the administration's vision. And in that execution, particularly now, when we're looking at some of the most incredible systems reforms that the state has seen in a very long time with CalAIM, our role is not simply about creating the rules of the road and pushing them downstream. What I find to be the most important role that we have is to actually be in the community, listening to incredible partners like these, and as Gabriel very eloquently put it, creating the bridges. Because there is a lot of work that goes on in the community every day that supports that higher level vision of healthcare in California. But the systems and the connections between those community organizations that work in the community doesn't always exist. And so, the traditional managed care model has very much been focused on, we get someone in for a primary care visit and we pay a claim and we move on. But really where we're headed into the future and what we're focused on, what I'm personally focused on, is really creating more of that connectivity between the community into this kind of, I would say, a little bit harder, more traditional system of care. because we know that the systems that we've been working in today, they're fundamentally not meeting the needs of our communities. And so we have to become more and more flexible in how we do things. I love, Bethany talking about lived experience of the incarcerated population, because the new community health worker benefit is really focused on how do we make sure that individuals feel supported by the system and can actually access that system in a way that makes sense for them from a day-to-day perspective. And, Meredith and the work of Maven to make sure that our physicians are supported, that our physicians have what they need every day. That's on me. That's on me as a health plan to make sure not only do those connections exist, but we're bringing those partners to our physicians so that they know what resources are available. It's really, I believe it's time for the healthcare system, for health plans to kind of break the traditional model. We've got to be more flexible. We have to be more community focused. We have to be in the community, on the ground, on a daily basis, because that's where change occurs. And then it's up to us as health plans to take those pilots, those community-based organizations work and blow it up large scale. The things that work in one place can work in other places, and it's up to us as health plans to support that work and make it sustainable. It can't just simply be, we're going to provide you a grant and we're going to walk away. It has to be about creating the contracts, creating the connections, and making sure that it's sustainable on the ground so that we don't lose ground when things like, all of this initial investment goes away. And so that's really what I'm focused on, and what I've asked my team to focus on is we've got the rules of the road from the state. Now, how do we help everyone kind of come into that system in order to make it sustainable in the long term?
Yeah, it's really great. I think sometimes when we're in the public facing serving kind of world, it's easy to look to the state to implement these, especially these monumental changes that are being proposed. And really what I'm hearing you say is it's going to take all of us working together to implement these successfully. And we can't look to the state or the government to implement them. We really have to work together. So thank you so much for that. I'm going to go to our capper question and give everybody a chance to respond. We've heard a lot about all of the amazing work that y'all are doing in your communities, and thinking more broadly, what do you think are the most important things that the state, local government, health plans, providers and advocates really need to do collaboratively to support implementing these innovative models like the ones we've discussed today? And I'm going to start with Meredith.
That is a great question. And honestly, I think the answer to that question could fill a whole another hour of conversation in and of itself. But first off, I think I'd be remiss not to recognize and appreciate the support we've received from Molina Cares. And truly, Molina Healthcare is leading by example. With their support, we're able to expand our reach into medically underserved communities in California. And really through opportunities such as participating in this panel today, we're able to raise awareness of Maven Project and other great organizations, as well as our mission. We all know California is a very innovative and progressive state that's pioneering new models of care delivery. And my hope and the hope of everyone on the Maven team is that we'll see this spirit kind of catch fire across the nation, especially after seeing the success of programs like the Maven Project in California. So not only would financial support and continuing to raise awareness of inequities in healthcare be beneficial, but I also think there's significant opportunity for organizations working in this space to convene, just like we're doing today, to share best practices in order to advance our common cause. And additionally, I wanted to mention that, especially in the realm of telehealth, it's important that the regulatory landscape continue to evolve at the same pace as innovation. What we're seeing is that, especially since the start of the COVID-19 pandemic, there's just been a boon of interest in telehealth and exploring ways that we can leverage technology in support of that quadruple aim of healthcare. So improving population health outcomes, improving patient satisfaction, reducing healthcare costs, and increasing care team satisfaction. But really, lagging regulations can stifle that innovation and growth in this sector. So in order for us to continue to see innovation blossom, all stakeholders really need to continue to advocate for the evolution of the regulatory landscape in concert with innovation. And the last thing I'll quickly mention, and I think it's important to stress, is that community health centers and community organizations, what they can do and what they already are doing in many places is they can address the social determinants of health that we've already heard from all of the panelists today throughout this presentation, how important the social determinants of health are. But providers and other healthcare workers can screen patients for health-related social needs and really connect those patients with other community programs and services and help patients access those services. And really importantly, as well, is that healthcare providers and other organizations need to be constantly in communication and collaborate to ensure that the programs and the services are adequately aligned with the patient's true needs.
Really eloquent response. Thank you so much. Bethany, how about I send it over to you for the same question?
Sure, thanks. So I've spoken about, from a decision-making level, the need to incorporate people impacted by incarceration in every step, right? So planning, implementation, evaluation of services. And this is so important because of the way that policies of mass incarceration have really systematically removed Black and Brown individuals from society and from public discourse and from decision-making. So we need to hear again from these communities about what services are most meaningful to them. For example, we saw with the Affordable Care Act, when Medicaid was expanded, that having an insurance card in hand didn't necessarily translate to people actually using services in the community. So right now with CalAIM underway, with this massive reform of Medicaid, and that's targeting all the populations we've been talking about today, it presents this really exciting opportunity to improve the health and well-being of people impacted by incarceration, but really only if decision makers and health plans value the experience and the input of these individuals. And I think this is going to require some creative ways of like reaching these populations for their input. But that's work that our organization is committed to. I could speak at length about other needs that people coming home have to live well, but to name a few big ones: housing, specifically medically supportive housing for individuals, such as like a board and care type setting, employment opportunities, again, minimizing some of those barriers to employment, access to technology and education to use technology, as well as clinical services that are specialized and trauma informed. We know that all of these would take a collaborative effort to achieve and ongoing funding. So not just, a one-time funding source, but funding ongoing to support meeting the basic needs that people who are coming home from incarceration and wanting to start over with their lives need to kind of get reestablished in their communities.
I really appreciate that. I think what it brings up for me is, we see this underutilization of necessary services on the front end for these underserved communities. But then when we get to deep end services, the more costly, the more traumatizing, we see an overrepresentation of some of our, underserved communities. And so it is this conundrum, and the absolute right answer I hear everyone saying is involve the people that we're trying to reach in the designing of the programs and the implementation. So thanks for continuing to, raise that up, Bethany. I'm going to move on to Gabriel to answer the same question. Let me know if you need me to repeat it, Gabriel.
No, just help me with answers after Meredith and Bethany took all the brilliance and genius and everything that I would have underscored and put in there. I just want to underscore everything my colleagues just said. So the one thing that was left on my list, though, is that, in order for any of this to be achieved, we really need to focus on strengthening the nonprofit infrastructure. And I'm speaking, self-servingly as a nonprofit organization, but there was a lot of pressure placed on us as nonprofits to expand, to implement these innovations, to bring forth those community members to be a part of the advisory council. There was just a lot put on us as nonprofits. And so we also identified that there's been a historical disinvestment and slow investment in the nonprofit infrastructure. And so that would be the first thing that I'd highlight. And I think within that, we often forget about individual leaders, right? I am Black, I'm brown, I'm queer, I am also a person living with HIV. And so, as a leader who comes from the community that I am serving, I don't often see all of my peers and colleagues get the same opportunities to cultivate their leadership, to bring forth their disruptive innovation, to help participate in the implementation of these services and ideas. And so I do think that we need to reduce the barriers for more nonprofits nonprofits to emerge in this space, for more organizations and leaders to be able to exist and cooperate and participate in these implementations. So that would be my other big point. The third one is courage. I know that we have to call out the elephant in the room, that there is a lot of political things happening around us right now. And for those of us that are from various vulnerable communities, it is a very scary time of the things that we see around us. So particularly for the communities that we serve, we have to understand that if we are feeling that as privileged people, myself included, just imagine what the feelings are of the population we serve. So with everything that we do, we are going to need to do it with a degree and a strength of courage.
Yeah, gosh, that really just touched me when you said that. I feel that I'm right there with you. And I think we're all going to have to be in this together with locked arms to really support our communities that are so fearful right now, rightfully so. So thanks for bringing that up. We're going to turn now to the Q&A portion of the session. And I have a couple, but I'm just reminding you all to put your questions in the Q&A or chat feature so we can respond. I'm going to start with a specific question for Gabriel again. You mentioned more funding, and from state appropriations to funding from government and plans. Where's the highest need that needs to be addressed? Is it care coordination? Is it outreach and linkage to care? What are your thoughts on this?
You know, every region is going to be different depending on your needs. I would speak on behalf of my more inland colleagues and those counties that are specifically have been under-resourced. So thinking about Riverside, San Bernardino, Contra Costa, Alameda, Imperial County. There are communities within those communities that have historically been disinvested. I would say from a more practical and strategic standpoint, there needs to be greater cooperation from the private and philanthropic sector. In all of the government funding that I've been able to access, you know, there are still limitations, there's parameters, there's actually things that make the problem worse. Sometimes you find taking the funding or accessing that program makes solving the problem even harder. And so there really needs to be a coordinated effort if we're trying to solve any issues with the private and philanthropic sector. And then just coming from my own public health lens, outreach and linkage for those sort of geographically isolated or geographically expanded areas. Outreach and linkage are often it's the hardest thing for our providers to do in our region. And so that's a place that I would personally begin if those resources were available.
I think it's such a good point. You know, outreach and linkage, when I think of it, that's a more upstream kind of intervention, right? And we know that our money goes farther when we're doing those upstream investments and kind of getting on that preventative side. And so I'm really glad that you brought that up, because I think that's a key in making the money go farther and ensuring sustainability. And so thank you for bringing that up. Okay, I'm going to go to the next question. I think this is a question for Abbie. You talked about supporting providers to make sure that care is more community focused, and how does that look like from a financing perspective? And do you think that providers need to be paid differently?
You know, that's a really interesting question. I think first and foremost, we need to maximize the funding streams that currently exist. So, you know, with CalAIM, there's some really incredible opportunities in terms of you know, the establishment of the enhanced care management benefit, community supports. And so really helping providers assess what they're doing on a day-to-day basis and how it fits into those funding streams. You know, a lot of our clinic partners have been doing some version of enhanced care management for decades, but maybe they're missing that little tweak, whether it's a social worker or it's a community health worker, whatever, you know, that investment is. We really need to help practices align with the state's funding mechanisms. And then it's really about how do we help partner with them to also maximize the opportunities that exist to make the care within their practice more efficient and more effective, and resources more available on a regular basis, so that we are really using what is out there. We don't want to leave any federal dollars on the table. The state has been awesome partners in trying to make sure that we're maximizing federal funding and really providing that downstream so that it isn't just simply sitting at the state, the county, or the plan level. It's actually getting out into the community. And so there's a lot of opportunity, and it's really just starting first with the conversation with your health plan and how to change your current contracting to take advantage of all those opportunities.
Yeah, such a great point. I think, braiding funding streams or leveraging funding streams, whether it's for sure the federal money that we don't always do our best job drawing down at the local level, but greater than that, it's like at the system level, the systems that benefit from these interventions should have equal contributions or equitable contributions into the solution, right? So whether that's our health systems, our educational systems, our law enforcement partners, our, whoever it is, we should all be around the table talking about how we can leverage our data and our financial resources to really improve the lives of our population. So thank you so much for bringing up that point. I'm gonna wrap up my portion. I just have to say again how honored I have been to moderate this panel and to hear from all of you. I'm so inspired by the work you're doing, and I'm so grateful for this opportunity. And I'm going to turn it back over to Abbie to close us out.
I just want to thank everyone for joining us today. Gabriel, Meredith, Bethany, you all represent some of the most incredible innovation going on in our local communities. And we are very blessed to have you all here today to really teach us what it's going to take to change the trajectory of healthcare into the future. And Karen, thank you so much for moderating today and really leading us through the discussion. And a special thank you to Supervisor Mitchell for kicking us off, and to everyone for attending today. As someone who's worked in the Medicaid space for a long time, it is always an honor to sit with such great people and talk about where there is opportunity to make the world a better place. So thank you all, and hope to see you soon.